Hello, good morning, one and all. I'm Dr. Varun Agarwal, and today I'm going to present on perioperative oncological and survival outcomes of robotic radical cystectomy with urinary diversion in females. Now, as we know, radical cystectomy has been the mainstay of muscle-invasive bladder cancer in both men and women. Minimal invasive surgery has actually revolutionized everything when it comes to our surgical practice. It provides many advantages like less pain, faster bowel recovery, thus leading to earlier discharge from hospital. Now, what about robotics? Robotics has further changed our practice and it gives us even more advantages of 3D magnified vision, favorable ergonomics, and easy suturing. If you see the current literature on robotic RCIC, majority of it is on men. That is because of higher incidence of bladder cancer in men. So our study mainly highlights female bladder cancer who underwent robotic radical cystectomy, and we highlight their perioperative, oncological, and survival outcomes. So this is a study in from 2012 to 2020, wherein 225 robotic cystectomies were done, out of which 41 females were included in the study. 40 underwent anterior exenteration, whereas one underwent general sparing cystectomy. We performed a retrospective analysis of all the demographic, perioperative details, postoperative complications, the pathological data, and oncological data. We followed certain components of the ERAS protocol, like no bowel preparation, early RT removal, early feeds, and DVT prophylaxis. The pre and the post-op investigations will follow with the routine ones, including blood and the radiological investigations. If you see, we had 41 patients in our study, 8 of them underwent neoadjuvant chemotherapy. Previous abdominal surgery was done in 13 patients, and they all underwent robotic surgery successfully. 38 patients underwent intracorporeal urinary diversion, while 3 underwent extracorporeal one, and 1 patient underwent general sparing cystectomy. What about our perioperative outcomes? Median console time in our series was 290 minutes with a median blood loss of 170 cc. The median hospital stay was 8 days. If we speak about complications, majority were grade 1 complications in 8 out of 41 patients, and the others grade 2, grade 3, 4, and 3 respectively. What about our oncological outcomes? We had recurrences in 7 patients, and the 5-year survival in stage 2 was 78%, whereas it was 41 in the stages subsequently. The 7-year survival was 70%. We calculated the 5-year survival in TCC and the non-TCC group, and it was 74 and 35% respectively. On your right of the screen is the Kaplan-Meier curve of overall survival, as you can see. Now, female muscle-invasive bladder cancer, there are 2 ways to treat. 1, anterior exenteration. 2, general sparing cystectomy. When we speak about anterior exenteration, what are the organs we remove? It includes uterus, ovaries, tubes, anterior vaginal wall, and the bladder. Now, why do we remove these genital organs? Reason being, they all have a common lymphatic drainage. There is no anatomical barrier between the bladder and the uterus, just like how men have. Men usually have tenovenous fascia between the bladder and the rectum. There's no such thing in women. And literature suggests that there is 7.5% involvement of genital organs in females. When do we do genital sparing cystectomy? It's usually reserved for non-trigonal impalpable tumors with no lymphadenopathy, for tumors which are away from the bladder neck. So, and it provides an advantage of preservation of sexual function and continence. So in our study, we performed general sparing cystectomy in 1 patient who was a 31-year-old female with an anterior wall tumor who desired to retain her uterus. What about intracorporeal urinary diversion? If you see a study by International Robotic Cystectomy Consortium in 2018, they suggested that it has favorable operative time in blood loss and blood transfusion. However, they reported a higher rate of high-grade complications. Bertolo et al. Refuted this in 2019, and they said that it in fact has a longer operative time but similar complication rates. What about our study? We performed 38 intracorporeal diversions and 3 extracorporeal ones. Out of those, 2 were in the initial part of our learning curve. 1 patient had to be converted to extracorporeal due to a vascular injury. Actually, we had a common vein injury while doing lymph node dissection, due to which we had to convert the patient to open. What about hospital stay? If you see Pasadena consensus, they suggest 4 to 10 days hospital stay of intracorporeal diversion. In our study, 7 days was the median hospital stay. And the reason I would suggest is because we followed ERAS protocol, we followed certain components of it, like early removal of RT and early starting of feeds. Complications. Now, this Korean study in 2019, they suggested minor grade complications of 31%, which is concurrent with our study. However, the major grade complication, there's a stark difference between the 2 studies, 16 and 7.3%. The reason being, Our study, we had a very strict selection criteria for surgery, and we used a purely robotic approach. Now, again, robotic approach provides an added advantage of increased precision, obviously. So, and we had a very strict selection criteria, patients who were absolutely comorbid and really above 90 years of age, we did not include them in our study. In the oncological outcomes, the lymph node yield, Pruthi et al. Suggested a lymph node yield of 19 with no positive margins, which was congruent with our study. We had a yield of 20 with no positive margins. Again, there is similarity in both the studies because robotic approach was used in both of them, which provides magnified vision and increased precision. Recurrence rates, if you see these two studies, they suggest different rates, that is 29% and 14%. In our study, it was 17%. Now, why is the difference in the Shim et al.? Why do they have such a high recurrence rate? The reason being they had a high rate of marginal positivity. What about the 5-year-old survival? If you see stage 3 and 4, this is precisely only for 3 and 4. This scoring study again reported a survival rate of 30 to 53%, which is congruent with our study of 41%. Reason being, majority of the patients in our study were operated within 6 weeks of diagnosis. It's said that in bladder cancer, the earlier you operate, the better is the long-term survival. So we did our patients mostly within 6 weeks of diagnosis with a very strict follow-up criteria. This is the Kaplan-Meier curve showing the 5-year survival in the stage 1, 2, 3, and 4. Again, TCC versus non-TCC. You see these two studies, it is historically said that non-TCC is actually a predictor of worse prognosis, which was confirmed by these two studies. And again, our study also suggested the same. If you see the 5-year survival, in TCC in our study was 74%, whereas in non-TCC it was 35%. So there is a difference between TCC and non-TCC. Any study is not without any drawbacks, and I would admit that our study was an observational single institute study of retrospective nature with a very small sample size. So what are the take-home messages? I would like to conclude by saying that robotic RCIC in females has an acceptable perioperative oncological and clinical outcomes. So exenteration should be done in females robotically. It is a safe and feasible option, and it should be incorporated in the mainstream approach for bladder cancer. Obviously, larger series are required for validation. Thank you so much, and I'm open to any questions.